السلام عليكم ورحمة الله وبركاته. شكرا لحضوركم. إن شاء الله نبدأ البيدياتريك إلكتروفيسيولوجي سيشن. طبعا نشكر الدكتورة حنيفة الرابطي على دعوتها لي إنها تشير، وعندنا دكتورة حتى معنا الدكتورة نفيسة وشيبة شيز كو تشير، ودكتورة نفيسة تشتغل في طرابلس في مستشفى جلال الأطفال. نعم. تربي شيلدرن هوسبيتال مستشفى جلال، هنا مستشفى جلال كلهم ما ايوه. وخلاص ان شاء الله نبدا السيشن. معنا البريزنتر الاول الدكتور عبد الهادي البراوي. الدكتور عبد الهادي بروفيسور وسينيور كونسلتنت بيدياتريك كارديولوجيست at the College of Medicine في الامارات UAE University. دكتور تفضل دكتور عبد الهادي البراوي. اهلا وسهلا بك. طبعا التايتل بتاع الدكتور عبد الهادي البراوي CPVT كاتيجوري Pediatric كارديا نيو جين ميوتيشن. انترستنج توبيك. نشوف الدكتور عبد الهادي شو بيقول ان شاء الله.
Thank you very much, Yusuf, thank you very much for the introduction. And very difficult to talk about it actually in front of the electrophysiology.
That's the surprise I did. That's the surprise I did.
Yes. Very difficult to talk in front of the electrophysiologist people who are really their area. And but what I'm talking about is actually more clinical. It is more sort of patients or family who presented to us in Al Ain Hospital. When I arrived there in 2009, this family, they have already 4 children died before age 12. And just they run, collapsed, dead. And luckily, two of them were saved when I started there in 2009. And one of them had brain damage and died last July, and the other one is still alive. And that's all for the 7 children below the age of 12 who are dying. So to start talking about that, and it is actually we got this novel mutation which we've never been published before, and we published it in the Molecular Medicine Impact Factor of 10 with the team from Amsterdam and Lausanne from in Switzerland. So just like introduction to you, it is more like clinical rather than pure electrophysiology, of course. Let's say. Bismillah. Okay, so all right. Bismillah ar-Rahman ar-Rahim. فإن شاء الله يعني I have nothing to declare, okay, disclosure, things like that. So objective actually is just to talk about the acute admission, how this family already I mentioned summary of that, and then family history, which is really surprising, and show you the family tree with extensive family members with cousin, first degree cousins, both mothers and fathers of the 2 families are brothers and sisters, and then some investigation that we have done locally in the hospital or in Emarat, and then we sent biopsy, and we have sent biopsy, and we have sent still biopsy plus bloods and so on. So we talk about that, and then the results of the investigation that we have got, and then the time or the inheritance of this arrhythmogenic diseases, and we go through that one. So this is the ECG. Actually, this is what we got from this child, Abu Bakr, or you can say, which is, as you can see, it is both negative and positive. Let's call it as bidirectional ventricular tachycardia, and he was at the time 3 years old. Luckily, he is only about 5 minutes from the hospital. Was playing in the park and running around, collapsed, and brought him to the hospital straight away, and was resuscitated in the emergency department in Al Ain Hospital. And then we went through the history, and we found very positive family history of sudden cardiac death. And then ECG on arrival, which is showing the bidirectional VT, and then dorsal Dupont-T's, which was inversed to sinus rhythm following DC shock. And then this is just about single lead from the. This is all what we have got.
هذا ياخذ دكتور دورسال يعني مش دورسال دورسال.
And even when we published this, the team from Amsterdam, they were not believing us. They say, oh, what is this not right, probably not, because do you have anything? Because how you can, a child, you cannot do exercise, ECG, you cannot, otherwise he will probably die. So we haven't done anything further. Okay. So, and this is the ECG at rest, which is actually showing the QT of 450. Otherwise, it's okay. And this is the family history of this two families. Both parents, as I said, fathers are brothers and the mothers are sisters. And they have, I can see 1, 2, 3, 4, 5, 6, 7. 7 children were affected. And this is the child who is still alive. And then one already died. And this is the rest of the other family, other cousins. And all of them, of course, from this family, they are died, except this one, who was actually died after 3 years from the diagnosis when we got his investigation and confirmed his. Okay, so BICU admission at the time after the attack, and he was comatose. He was there, and we have done MRI because when he started to walk, he was struggling around, and we thought brain damage or some ischemic problems or neurological deficits, but clinically he had no neurological deficit. MRI show was normal, and they started on magnesium sulfate and beta blocker empirically, and then stayed in the hospital for 6 months. This is strange. 6 months. Why? Because he has no insurance card and nobody can pay his ICD. So he stayed in the hospital, and subhanallah, in the morning we have the morning report. The team, everybody against me, discharge this patient, discharge me. I said, no, I will not discharge this patient. If you could die in the way or at home, then I'll be responsible. So, wallahi, subhanallah, the same day at night, he got the attack in the hospital. He was running in the corridor, and then he got the attack, and one of the residents resuscitated him and alive. Second day, nobody raised his voice at all. Everybody is quiet. And this is really dangerous to discharge this patient. And then we got for him ICD done in South Asia, one of the countries there, after getting money for the people. Because the people are really, the parents are poor, they couldn't afford to pay the ICD. Okay. So, first degree cousins, family history with the 2 sub-families there, family history of 7 out of 13 with the attacks, and all of them below the age of 12, presented all after exertion. With sudden cardiac arrest. And then 5 children had an arrhythmic episodes which was fatal, and 2 survived. Those who survived the episodes, 1 had brain damage and died in July last year. So, okay. So this. So here are the clinical features of the affected members. They are 7, and all of them, that was somebody skating, somebody playing, and then 1, I think, or 2, they were dancing in the school, and there were 6 at the moment out of 7 who did, and only 1 is still alive with his ICD. Okay. Only 2, they had congenital heart disease, infundibular stenosis with VSD, so we thought maybe it's just like pathology with no override, and then VSD with pulmonary atresia. So just. So we have, as I said, we have got the blood samples. Skin biopsy were sent to Lausanne and Amsterdam, and they have done the stem cells and formed the cardiomyocyte, and they tested these cardiomyocytes with the physiology as well. And here, that's all what we can say. Identify the homozygous here, homozygous with Y chromosome sequences. And the point of a mutation in the splice donor site of the 3 of TECRL. is the new mutation. So this is the new mutation, which is trans 2,3 enoyl coenzyme reductase-like, and then we have done screening for 75 members of the family, and we found 27 who were heterozygous carrier, and we counseled them and we informed them about the marriage and all these things. Okay. Next. So this is just repeating there. All right, so after this is the ICD interrogation, and that patient actually has got his ICD and stayed for 7 years, and then we changed the ICD after that. So with some source of the BVCs and no real VTAC. Okay, this is the publication that were done in the Embo Molecular Medicine at that time in 2016. So talking about, in general, the inherited arrhythmogenic diseases are one of the prevalent causes of sudden cardiac death, and in the young, and can be classified into disorders with or without structural heart disease. Those with structural heart disease is comprised of channelopathies, and such as the long QT syndromes, of catecholaminergic polymorphic ventricular tachycardia, which are caused by the mutation in ion channel or calcium handling genes that primarily affect the electrical activity of the heart. So if you go back for the long QT syndrome, which was discovered with the two professors, one of them actually was my supervisor in Dublin, Professor Ward, and Romano is from Italy, from German. So I have the honor that I have seen his patients who discovered this syndrome on them in 80 when I was in Dublin doing my residency. Other groups, actually the Jervin-Lange syndromes, here depends on what exactly the channelopathy is, potassium genes or in the calcium or in sodium problems. So the ECG at rest is usually normal for this new novel mutation. The diagnosis is made mostly from recording the an exercise ECG. Of course, children, we haven't done any exercise, but we are planning to do screening for them and see if they have any manifestation of BVCs or any evidence of VTs. And in ECG exercise and Holter monitor, planning to do it, and planning to take blood before and after exercise ECG to see how is the adrenaline levels and before and after exercise, and then genetic studies, and we plan to do all these genomic DNA extracted from the peripheral blood, as I said already, and we're trying to do those who are heterozygous. So this is a new papers came out, like case reports, that to show that patients still, even they are heterozygous, but they could manage the BVCs, but not real ventricular tachycardias, and we planning to, as I said, these 27 who are heterozygous, planning to do all the.
Dr. Hadi, 2 minutes, 2 more minutes.
So here is just the inherited arrhythmogenic diseases, structural heart diseases, and no structural heart disease, channelopathy problems, and channelopathies can be divided into genetic type and the acquired type. And all here the entrance and the out and in of the sodium, potassium, and calcium. Quickly, I think the same. Right. And screening is very important. That, of course, first degree relatives we have done, as I said, and then channelopathy genetic types. Mentioned already Romano-Ward syndrome and Jervin-Lange syndromes, and all these channels, different types, ranitidines and others. So the take-home messages there. So I'll finish before time now. Inappropriate arrhythmogenic disease are one of the prevalent causes of sudden cardiac arrest and death, and 30% of sudden cardiac death cases are due to unknown gene mutation, still not discovered yet, and then our novel mutation that we discovered, a sort of malignant form of the cardiac arrhythmia and caused by homozygous mutation, and we thought it is more sort of autosomal recessive type of disease. And these findings have implications for diagnosis and treatment of inherited cardiac arrhythmias, and then ICD implantation and nadolol are the recommended options. And our patient now is about 18 years, and he is on nadolol and already has the ICD. Any young patients with the syncope or palpitation, arrhythmias, syndromes should always be considered. And then wide QRS complexes tachycardia should be considered triple tachycardia until improved otherwise. And then, thank you very much.
Dr. Al-Hadi, bravo, very interesting case. This is basically a new mutation that you discovered in this family. So can you tell us about its CPVT? Like it also has some QT prolongation?
Yes, yes, it has, but it's not that much compared with the pure Rinaudian mutation. It's not that much, it's over 450 for a child. I think it's a lot. Some people, they say borderline. Yeah, so it's, yeah, but the others we almost the same.
Yeah. So I have a comment about long-QT syndrome. So from my practice, I had several cases with family history and all that. With our they usually test genetic testing. They don't depend on the resting EKG. They might test positive, although the resting EKG shows a normal QT interval. So it's a rule not to, if there is a family history, there is a risk, you just go right away to do genetic. I recently had a family, mom had long QT syndrome, brought her children for testing. I went and did EKGs, and one of them had prolonged, one of them, I don't know, it's not right. Yeah, one of them, the resting EKG showed prolonged QT interval. I consulted with the EP. Of course, I don't manage them myself. We have EP support. I consulted with EP. I was going to do stress exercise test, see if the QT will prolong with exercise. Usually, you measure at rest, and then after exercising, during recovery, at 4 minutes, check the QT interval. But the EP recommended, don't waste your time with exercise, just send them to me. We're going to do genetic testing. They usually meet cardiovascular genetics. So they don't trust the resting EKG.
It's normal, especially for those with the catecholaminergic tachycardia. Usually this is almost normal.
I remember the family was from Kentucky, and I referred them to Louisville. The EP doctor at Louisville was going to do all the genetic testing. I didn't hear back from them what happened with the genetic testing.
This is very important, and we should do actually screening and see if the other, because we need to counsel the other members of the family as well.
Okay. Shukran.
Okay. Let's move on to the next presentation.
Thank you, Dr. Al-Hadi, for a nice presentation. In my pleasure, we'll present Dr. Maryam Maidani, consultant pediatric cardiology in National Heart Center, assistant at Benghazi University Pediatric Department. She will present indication of cardiovascular electronic device in pediatric patient. Most welcome.
I put this topic because our society has a deficit. اللي تحت اللي بيعمل كده اللي تحت ايوه اللي تحت الانسان اللي تحت بيعمل فوق against logic. Yes, because in our society we have deficit in diagnosis, either electrophysiology, genetic, and even if the patient diagnosis, we have a deficit to medical innovation.
Yes.
Okay. I take this new guideline from this article, which is publishing in 27 of March 2024. This guideline is taken from Cardiology and Arrhythmia European and American Society, European Society of Cardiology, European Heart Rhythm Association, up to Pediatric and Congenital Electrophysiology Society, which is for our management of the patient. We found in pediatric and congenital electrophysiology statement in all indication and management of pediatric cardiovascular implantable electronic device in 2021. It is late compared to the adult patient. In 2021, the European Society of Cardiology guideline for management of ventricular arrhythmia, and in 2023, Heart Rhythm Society guide on electrophysiology basing. Okay. A new guideline in 2021 for pediatric and congenital electrophysiology society is based on class of recommendation and change in the class of recommendation mainly on the level, for example, from the class of recommendation 2A to class of recommendation 2B. We have a small paragraph about the pacemaker or ICD in the pediatric, which is most common in this congenital complete AV block and in postoperative complete postoperative heart block. Okay. This is about the class of recommendation and level of the evidence, which the guideline according to this class and level of evidence will put a guideline for pediatric, for ICD, or for pacemaker. The most common is the postoperative AV block, which is most common in waiting for 7 to 10 days for implantation of heart block, or patients who develop syncope after history of transient postoperative heart block, or any advanced second or 3-degree heart block in exercise. So this is the other indication of postoperative AV pacemaker implantation after cardiac surgery. About the AV block, either congenital AV block, according to the type of congenital heart disease, if complex, to be he changed from the more than 60, so 70 to more than 70, and those with neonate, with asymptomatic neonatal with heart rate, mean heart rate less than 50 to more than 55. This is for the time will not mention, but also for AV block for any symptomatic patient with dilatation of left ventricle, and for any wide complex QRS or complex ventricular ectopy or ventricular dysfunction. This is in summary, sinus node dysfunction. Pediatric and Congenital Electrophysiology Society recommended class 1 and class 2 for permanent pacemaker implantation for a symptom, regardless the heart rate. If the patient is symptomatic, I will put a pacemaker even at a higher heart rate. Heart rate in S-node dysfunction associated with complex congenital heart disease for any bradycardia less than 40 per minute, and will use atrial pacing better than ventricular pacing for more physiological benefit for the patient. This is the other for the time. Only for a new recommendation here, class 2 is the left ventricular dilatation with Z-score more than 3 associated with ventricular dysfunction and mitral regurgitation will be both permanent pacemaker or other indication. Post-operative block, a new recommendation is a class 2B for the permanent pacemaker implantation before the 7 days of the surgery, if we not expected to the resolve the heart block, there is extensive injury to the conduction system, or in some congenital heart congenitally corrected congenitally corrected TGA, and heteroataxia syndrome, because those are risk for complete heart block. Idiopathic symptomatic advanced to or third degree AV block, not attributed to reversible causes, you must insert the pacemaker, permanent pacemaker. Okay, that's just for the time. For other indication for those with the neuromuscular disease and other progressive cardiac conduction disease in Kearns-Sayre syndrome and myotonia dystrophica, this will need elective pacemaker insertion due to malignant ventricular arrhythmia and the progressive nature of the disease. Okay. Neurogenic syncope. She moving from class 2 to class B for those child with breathing holding spells with recommended cardio inhibitory response with prolonged syncopal episode and post-anoxic seizure. This was the class is recommended, but now it is not recommended because it's a self-limited disease. When the child is growing, the problem will be resolved. This is for ICD implantation in cardiopathy and cannulopathy and congenital heart disease. This is a recommendation. In summarized, we in every child with hypertrophic cardiomyopathy, there is calculated the risk for sudden cardiac death at 5 years, which is including left ventricular wall thickening and left ventricular outlet obstruction, and family history of sudden death and history of syncope. In cardiomyopathy, pediatric and congenital electrophysiology recommendation is more specific for pediatric age. Cardiac arrest and sustained ventricular tachycardia and hemodynamically tolerated or not is a class 1 for dilated cardiomyopathy and hypertrophic cardiomyopathy. Arrhythmogenic cardiomyopathy is a class 1 recommendation for is reserved for cardiac arrest and not tolerated sustained ventricular tachycardia. Pediatric and congenital electrophysiology consider risk factor including sudden cardiac death in the family and unexplained syncope, and massive left ventricular hypertrophy is a class 1, where in European guidelines do not include family history of sudden cardiac death in hypertrophic cardiomyopathy for as a risk factor. Okay. Yes, in dilated cardiomyopathy, we recommended pacemaker insertion for in the presence of syncope or left ventricular ejection fraction less than 35 in optimal medical treatment, which move from class 2B rather than class 1. The reason because the low incidence of sudden cardiac death in dilated cardiomyopathy and the risk of ACD insertion. Patient with non-compaction cardiomyopathy and primary prevention ICD implantation should be follow dilated cardiomyopathy, where the restrictive cardiomyopathy must follow the same indication of hypertrophic cardiomyopathy. In myocarditis, European Society of Cardiology guideline of an acute phase of hemodynamically not tolerated sustained ventricular tachycardia considered as class 2 indication for ICD. In chronic myocarditis, ACD is recommended for hemodynamically not tolerated sustained monomorphic ventricular tachycardia. This is a class 1 indication. Where in hemodynamically tolerated sustained monomorphic ventricular tachycardia is considered a class of recommendation 2A. This is about the recommendation of insertion of ICD in long QT interval. There is also 1 to 3 long QT risk factor we must be calculated. Every child with long QT interval must go to genetic study, because some type, long QT type 3 is not responding to the beta blocker, okay? Which is like in our society, we didn't have this genetic study. Recommendation in long QT syndrome, infant with bradycardia and function 2 to 1 AV block, and severe prolonged QT interval more than 55 millisecond, 550 millisecond, according to genotype. And every type must be according to genotype. Specific genotype in Jefferson, Lange, Nelson, and Timothy syndrome, and any history of barrier sudden cardiac arrest, survival from sudden cardiac death, or recurrent syncope. Symptomatic patient on beta blocker and genotype specific therapy. ICD must be considered in high asymptomatic patient according to 1, 2, 3 long QT risk calculator. And those with short QT interval, according to duration of a QT, this more than 320 millisecond, and those less than 360 millisecond and arrhythmic syncope, and those more than 360 millisecond and family history of sudden death, and those less than 40 years.
Dr. 2 minutes.
2 minutes. Okay, well, 2 minutes. This is about this catecholinergic. We're not talking about, but polymorphic bidirectional VTAC are downgrade from class to class 2B. Okay. Brugada syndrome, we recommended the ICD in sustained spontaneous ventricular tachycardia and aborted of sudden cardiac arrest. Okay. In congenital heart disease, in congenital heart disease, in those with non-tolerated VTAC or cardiac arrest caused by ventricular fibrillation, in patients with pathology of Fallot, or those with preserved ventricular function, with symptomatic sustained monomorphic ventricular tachycardia, catheter ablation is an alternative to ICD. And those with congenital heart disease with symptomatic heart failure in New York Heart Association grade 2 and more, and left ventricular ejection fraction less than 35% despite 3-month optimal medical treatment. This is about, we'll have this problem also in ICD with pacemaker because of this weighted patient. Those on less than 50 kg will do an epicardic. Those more than 15 kg will do transference. Those for ICD less than 30 will input epicardic and coil, and those more than 30 can be transfers. Now there is subcutaneous ICD insertion in the adolescent. This is the 7-take-home message: isolated sinus node dysfunction, no minimum heart rate, but symptom and both duration. Those presence of lead, gadolinium enhancement in cardiac magnetic resonance is a new risk factor for hypertrophic cardiomyopathy and dilated cardiomyopathy. Pathognomonic gene mutation is an important risk factor in arrhythmogenic cardiomyopathy and long QT and dilated cardiomyopathy. Decision of pacemaker implantation depending on weight and congenital heart defects, ventricular function and other comorbidity. Post-AV block period of observation at least 7 days. Conditions such as Green-Sire syndrome, these need elective pacemaker insertion. Pediatric recommendation have low level of evidence. B and C, we lack a randomized study. Level of evidence A are lacking because it is new recommendation for pediatric comparing to adult. Okay. Feature direction هي lead less pacemaker in the future. And single extravascular ICD is another new system for useful in some children. Okay, thank you.
شكرا دكتورة مريم. تسمع في صوت واضح؟
لا لا
مفيش صوت. تمام.
تمام.
شكرا دكتورة مريم. اتس بيج توبيك بصراحة وبيج تاسك يعني. هو دكتورة حنيفة احنا لو ما عندكش مانع ناخذ شوية أسئلة بس تكون فريش يعني حتى لمدة دقيقتين أو ثلاثة ونقعد في التايم وبعدين once we conclude لو في حد عنده سؤال we can take it يعني لأن أكيد تكون أسئلة. فطبعا الجايد لاينز ما بين الادلت والبيدياتريك ما فيش هيوج ديفرنس طبعا whether it's primary prevention or secondary prevention زي ما الدكتور الهادي براوي ورا الحاله هو السي بي في تي which is in one of the indication for ICD. شفت حتى الحالات الثانيه long QT syndrome which is it's the most common arrhythmia يعني او let's say channelopathy, the most common channelopathy that we see long QT syndrome. فالجايد لاينز don't really differ. طبعا it's a very difficult task لما يجينا patient with sudden cardiac death. How can we diagnose the condition؟ يعني طبعا ICD is used for secondary prevention. لكن how can we manage the patient? How can we reach a diagnosis? And sometimes we have to use certain clues to go which way. يعني is it CPVT? Is it long QT syndrome or short QT syndrome, which is very very rare. It's very uncommon. أو it's a difficult task يعني. دكتور الهادي البراوي ما شاء الله يديد جريت جوب كنت وصلت دايجنوسيس والعيله. في اي سؤال بالنسبه للاي سي دي فور انديكيشنز دكتوره؟
ممكن اقول بصوت عالي؟
دكتوره.
دكتوره مريم، دكتوره عبد الهادي. نعم. هي المشكله في الاطفال في تركيب الاي سي دي يعني الحجم بتاع الجهاز فكمان كنت بالنسبه لوزن الطفل بس برضه بيبقى الحجم كبير للاسف الاطفال بيتحركوا كتير وكده فيحصل ايروجن وبري ايروجن ونضطر نشيل الديفايس. فالقرار بتاع اي سي دي الطفل ده اتاخد بحكمه وطبعا جاي للجينيتك تيستنج وكده لكن اتس نوت ان ايزي ديسيجن تو انديكيت او تقول لا لازم يركب اي سي دي. طبعا القرار صعب.
بالنسبه لي was very easy بصراحه القرار for this patient.
Yeah, for this patient.
هو بالنسبه للسي بي تي البيتا بلوكر واللي بيضيفوا لهم كمان كلاس 1 ايكونايت احنا في مصر ما كانش عندنا في لحد وقت قريب فبندي لهم بروبافينول كلاس 1 سي اديشن وبنستريس التشايلد على الاستريس تيست عشان نشوف هيعمل ايه. المشكله في السي بي تي مع الديس شوك الطفل بيضطرب فبتيجي تاني وبياخد مالتيبل انابروبريت شوكس فهي بنفضل ان احنا نحاول قدر الامكان ان احنا نقللها. ليفت سيرفايكال ماستكتومي could help in such conditions. الاي سي دي في الاطفال اللي بتركب جراحه اللي هما بيلفوا الديفبريلاتور ليد حوالين القلب. كان زمان انا في التريننج بتاعي سنه 90 في امريكا كان في الابيكارديال باتشز اللي كانت بتتحط وتو سنسور ليدز على الار في تو سنس وكانت البطاريه بتتحط في الابر ابدمن فدي ما بقتش موجوده في الصناعه. ما اعرفش في امريكا العيال بيكتبوا لهم يعني الاطفال بيكتبوا لهم ايه اللي هو نفس الليد ويلفوه صعب شويه.
في epicardial leads دكتوره بتستخدم طبعا I'm not involved in pediatrics بس I understand there's epicardial leads لكن لو patient is like adult size and irregular ICD.
بتتكلم بقى على الاطفال اللي هي بتتكلم على 3 سنين و5 سنين
epicardial.
هو في لكن هي الليد اللي بتتحط يعني في مصر بيعملوا عند مجد بياخد الديفبريلاتور ليد بتاعنا ويلفوا حوالين القلب والسنسور يبقى متشابك يعني مش ده الايديال. فانا كنت بسال بس في بلاد بره بيعملوا
epicardial او ممكن حتى كويل you can put a coil يعني في الاس في سي او في الهارت يعني والسبكيتيريس اي سي دي is a very good طبعا في البيجر سايز epicardial either way. خلاص والدكتوره نفيسه في اي سؤال او اي شيء؟ في حاجه؟ اوكي I'll present دكتور عبد الهادي الدكتور الهادي براوي again المحاضره الجايه. الدكتور الهادي البراوي هيقدم لنا approach to management of congenital heart block.
Okay, Bismillah. Again, the communication with Dr. Hanifa, so we reached to what exactly to talk about, and she gave me two choices to talk about the Welsh WBW syndrome or to talk about the management of congenital heart block. So I choose this one, and I thought it's straightforward, but actually I have to do more research and work more on So I have no any relevant disclosures, and just objectives, introduction, classification, and then etiology, maternal risk factors, clinical presentations, and therapeutic options. This is what exactly I thought to cover, but mostly concentrating on the risk factors, clinical presentation, and the therapeutic options. And my talk actually is a continuation of Dr. Sorry. The two talks but already covered. Yeah, all right. So the presentation is AA is 30 years old pregnant woman. She presented to the hospital with trial contractions at full term, and the fetal heart rate was 40 per minute. The newborn ECG is here, so it's not really good, but I have just chosen the lead, only one lead for our fellowship of trainees in pediatric cardiology. And as you can see there, there's no any relation between B with Paris complex, so you can complete dissociation of the B and Paris complexes. Okay. So the definition, like for the complete heart block or congenital heart block, is the that's what I'm concentrating on for this talk. And status of the cardiac AV conduction and diagnosed in utero at birth or in the first month of life. And then the incidence is about 1 in 15,000 ila 1 over 22,000 live births. And 2 to 5 mothers with the SLE. Actually, a lot of people they think every mother with the SLE could have this, but it's only not that common. But 2 to 5% only. But for further pregnancy after that and further the fetal and more getting more risk and increase more and more. Okay. So classification is just to talk generally about the first degree, second degree. I'm sure all you know that. And so first degree heart block, second degree heart block. Most of the time the heart rate is normal, but there's no any bradycardia. But it could sometimes happen, but it's not that really common. And for the third degree complete heart block, that's the problem here. And I remember I have seen maybe 15 of these between different countries, in Ireland, Sweden, and England. And Emirates as well. So, and the cause of congenital heart block, most prevalent with autoimmune diseases, 55 and 90%, where we see patients or neonates who are diagnosed in the first month of life or in utero with 50 to 90% autoimmune diseases. Generally, girls and boys are the same. In autoimmune diseases, and then isolated congenital heart block, that's more girls than boys more than girls, and then associated with the congenital heart disease about 5 to 40%. And commonly the congenital heart disease are associated with the complete heart block is the transmural arteries, atrial septal defect, and also isomerism. And then we come to idiopathic, where you don't find any relation, only diagnosis. And then these are all, like, or almost all, associated with the genetic abnormalities. The maternal risk factors are, of course, the advanced maternal age, which increases the levels of anti-Ro and SLA. So the Jubilee syndrome and the or anti-La SSP antibodies. for both jugular syndrome and the systemic lupus erythematosus. Only 2 to 5% of pregnancy in SLE jugular syndrome women is a result in congenital heart block, but with the further pregnancy, as I said already, that increases more and more with further pregnancies. And this can rise subsequent to up to 25% or more. And then hypothyroidism, low vitamin D levels are the other risk factors, presence of structural heart disease, as I said already, and then family history of congenital heart disease, congenital heart disease, yes, and maternal infections. Mostly respiratory tract infections and other minor infections or other severe infections as well during pregnancy. And the clinical presentation, so fetal bradycardia, heart rate less than 100, that's by definition. And then could be congestive heart failure, could be the hydrops fetalis. And echo is very, very important, is the gold standard for the diagnosis, to see the problems that could create on, of course, the heart rate is easy to count, but the echo should give you all these what exactly there to look for the pericardial effusion, to look for the reduced ventricular function or not, the ventricular dilatation, and hyperechogenicity of the left atrial walls. So the first sign is the bradycardia, and by definition less than 100 for a fetus. And then differential diagnosis of fetal bradyarrhythmia, transient bradycardia, partial complete heart block could be, but then some of them they improve, some of them they're getting worse and getting into the complete heart block instead of partial. And autoimmune diseases, as we already mentioned, about they could present with the endofibrinoelastosis, endocardiofibroelastosis, valve diseases, dilated cardiomyopathies, and the markers of poor prognosis and higher mortality are with, of course, with the more problems like fetal hydrops, ventricular response less than 55 beats per minute, and then prematurity, complex congenital heart disease. Here, basically, the treatment of the congenital atrioventricular block in utero. So that's autoimmune disease, as we mentioned already. Observation most of the time if the structural heart is structurally normal with the class 1A with this level. And then sometimes for dexamethasone can be introduced where there are first or second degree block with evidence of inflammation, pericardial effusion, ventricular dilatation, hyperechogenicity of the atria or atrial walls, and reduce it by ventricular function. And then prophylactically or to reduce the mortality and cardiomyopathy. Sometimes IVIG, the venous immunoglobulins, can be given, and then actually not much recommended with the 2-4 prophylaxis. And beta blockers when the heart rate is low or less than 55, or there are fetal hydrops, congenital malformation, and cardiac dysfunction. Cardiac malformation observation here for if the heart rate is done 55 per minute with the fetal hydrops and beta adrenergic agonistis as well should be given, and congenital malformation or cardiac dysfunctions. Adiabatic, just if the patient is the fetus is stable, so just observe and follow up. Recommendation for pacemaker, that's exactly what we mentioned already now for the ICD insertion. So less than 10 kilo, 10 to 15, almost the same, and then epicardial, VVIR, and then at the left epicus, and mostly of course all pediatric, especially the young pediatric age groups, all of them will insert like the below the costal margin, and then leads are put over the ventricle at the epicus, and then endocardial when the epicardial axis fails, and then those between the weight between 10 and 20 is almost the same, like, but for the epicardial we go the same with the VVIR at the left at the apex of the left ventricle, and the endocardial mostly go for DDR in case of specific hemodynamic indications. And then more than 20 kilo, these are endocardial mostly, and epicardial if endocardial fails. That's the recommendation. And then DDR or VVR depends on the situation. For endocardial, we go for the right ventricular septum, and then the the IR or the epicardial must be the same as for the left ventricle abacus or free wall. Then concomitant with the other cardiac surgery sometimes, as the patient could have structural heart disease. So take-home message are like congenital complete heart block. It is rare, but treatable cause of pediatric mortality. And then the main etiology is mainly autoimmune. It is associated with genetic polymorphism and inflammatory markers, calcifications of AV node and conduction fibers. Maternal risk factors are higher in cases with the autoimmune diseases. Fetal echocardiography remains the diagnostic gold standard, and effective antagonists of anti-inflammatory cascade are of importance. Most cases, monitoring of the pregnancy with until birth is all that is recommended or needed. Thank you very much.
شكرا دكتور. في اي سؤال للدكتور؟